All right. It seems like our attendance is starting to trickle in just a few more, so we're going to plan on getting going. So thank you again to everyone who has joined so far. My name is Andy Webb. I'm a neurocritical care clinical pharmacist at Massachusetts General Hospital, and I'm excited to be this month's moderator of the Neurocritical Care Society's Pharmacy Section Journal Club. Just a few quick announcements before we get going. Thank you to everyone who's joined so far and has already put themselves on mute, but just a brief reminder to make sure that you remain muted while the presenter presents their journal club, and we'll save time at the end of each presenter's presentation for questions and discussions about the individual article. We have two great presenters today who are going to be presenting two individual articles. You can, of course, listen to the presentation on the Zoom here, which you definitely should do, but also you can follow along on Twitter, where there'll be an active discussion about pre-planned questions about the articles. We can get some additional participation of individuals who are interested in discussing more about the article. And so the first presenter that we have today, I'm excited to introduce Dr. Ashley Lamasek, who is a neurology resident at Grady Memorial Hospital. Ashley will be presenting on intravenous levothyroxine after brain death for heart donors. Dr. Lamasek, I'll hand over the stage to you.
Thank you so much. Let me pull up my presentation. It says I cannot. Oh, there we go. Sorry. Okay, can everyone see my slides okay?
Yes.
Awesome. Thank you so much. Thank you, everyone. My name is Ashley Lamasek, and again, I am the PGY2 neurology resident at Grady Memorial Hospital, and I'm excited to have this opportunity to be presenting this journal club to you all. Before we dive into the journal club, I wanted to make sure we all had a great understanding of the history behind organ transplant and to really set the stage for a journal article. First, going into transplant. Transplant actually started in the 18th century, and we didn't start seeing success until the 1900s. The first successful transplant was 70 years ago in 1954 here in the United States. And with new technology and medications, research is constantly growing to allow us to optimize our donor care. The US Congress passed the 1984 National Organ Transplant Act, or NOTA, and this addressed the nation's critical organ donation shortage. So this helped improve the matching placement process and also established the Organ Procurement and Transplantation Network, or OPTN, which helps maintain that national registry for matching. And it oversees multiple transplant centers and organ procurement organizations that you may have worked with at your hospital as well. OPTN does release their metrics and it's available online. So in 2022, they had an annual record set where over 40,000 organs were transplanted. And you can see all the numbers here as well for your reference for all the organs. And in the graph to the right, you can see that we're constantly increasing the amount of organs we're donating. And for deceased donors, that accounted for about 15,000 of these transplants, and majority of our patients that are deceased donors, they are transplanted from brain death patients. And we saw about an increase of almost 8% in this number from the previous year. I do want to help the audience compare the difference between circulatory death versus neurologic death. So first, with circulatory death or donation after circulatory death, DCD, this is when a patient who wants to be an organ donor, they ultimately decide, or their family decides, they want to withdraw from care. And so they would then be declared dead at circulatory arrest. And then there's going to be this observation period for at least a minimum of 2 minutes. And this is solely just to ensure circulation does not spontaneously resume. And then we can begin harvesting organs. Now, death by neurologic criteria, or brain death, as we all know, is the complete and permanent loss of all brain function in the brainstem and in the cerebrum in the setting of a neurologic injury. So in these patients, we see persistent coma, We see no brainstem reflexes, so this is when their pupils don't respond to light or they do not have a cough or gag reflex to throat suction. And then they also do not pass an apnea test. So how brain death relates to this topic, and when we start talking about levothyroxine into the journal article, when brain death occurs, there's injury and we see an increase in intracranial pressure. This increase in intracranial pressure, we can see dysfunction in the HPA axis. We see a stress response. There's truly just a cascade of events that happen. And we see hormonal depletion, which they have seen our patients just become hemodynamically unstable. Now, switching gears from brain death, the cornerstone of deceased donor care is hormonal resuscitation, and some studies have indicated that empirically treating our patients with hormones that they may have potentially lost from the brain injury will promote hemodynamic stability. And once neurologic death is declared, our intensivists, our team can help play a role and collaborate with our OPO to help optimize this procurement process. Now, hormonal resuscitation therapy, like I mentioned previously, there's going to be brain damage that would alter the HPA axis. And then from there, from the anterior pituitary gland, we would see that cortisol and thyroid are affected. So low levels, then they found that there would be hemodynamic instability. And so from here, if a patient's not responding well to fluids or vasopressors, this is when we can consider giving them exogenous hormones. So this includes thyroids, steroids, antidiuretic hormones, so vasopressin or desmopressin, and then insulin. As we've seen that these agents can help increase the hemodynamic stability, decrease the amount of vasopressor requirement, and then also increase the amount of organs transplanted. The SCCM, Society of Critical Care Medicine, came together for a consensus statement to help us provide the best care we can for potential organ donor in the ICU. In 2015, they came together to create this, and of course, I'm going to highlight specifically thyroid replacement since this is going to be the focus for today. So SCCM recommends that thyroid replacement therapy should be considered when a patient is hemodynamically unstable and or if they are a potential cardiac donor with abnormal ejection fraction. So they define this as less than 45%. And then they do provide guidance on how to administer the thyroid hormone. Oftentimes you will see T4 or levothyroxine being used, but they do provide recommendations for T3 as well. T4 is converted into T3 like we all know. There is a slower onset compared to T3. It has a longer half-life as well. And then in terms of adverse drug effects, we would see tachycardia, tremors, fatigue, arrhythmias, and hypertension. Now going to how thyroid hormone came about in the aspects of donor care, there's been some observational studies, some randomized controlled trials. So briefly looking over these two trials, the retrospective observational studies, you can see that they're pretty large observational studies that compared various hormone resuscitation regimens. And overall, what they suggested and what they found was that more organs were transplanted in those that received thyroid hormone. However, due to the nature of the study, we cannot infer a causal relationship. But overall, what we gathered from these two studies is that more organs were procured in the observational data. Now, looking at the small randomized control trials that we have available, largely all of these trials looked at mainly focusing on the hemodynamic aspects and effects that thyroid hormone can provide in these patients. And unfortunately, from all of these studies, they were unable to confirm if they actually benefited in terms of hemodynamics from the thyroid hormone. So what we got from here is that there was no proof of benefit in the randomized controlled trials. So tying all of this together, there's not much high quality evidence. Despite the lack of support, this still remains a standard practice today. And so since treatment has been associated with risk to the donor, and some literature has also found higher rates of early graft failure, the question is, does levothyroxine benefit our donors and recipients? And that's where we will switch gears and start talking about the journal article from the New England Journal of Medicine. This article was by Dar and colleagues and was published in November 2023, looking at IV levothyroxine for unstable brain dead heart donors. The purpose of the study was to evaluate the hypothesis of what IV levothyroxine increasing the rates of hearts transplanted from hemodynamically unstable brain dead organ donors. It was a multi-center parallel group randomized trial at 15 OPOs from December 1st, 2020 to November 6th, 2022. And as you can see here, all the OPOs involved spanned across the nation. For population, we included deceased patients receiving care that obtained authorization for organ donation from the OPOs within 24 hours of declaration of death. And then it was randomized in a one-to-one fashion where some of these patients received IV levothyroxine at 30 micrograms per hour for over 12 hours, and they reconstituted this medication in 500 micrograms in a 500 milliliter normal saline bag. And then the control group, they received an equivalent amount of the normal saline. And just to note, T4 levels were drawn before the infusion and also before harvesting the organ. For the protocol of the study, like I said, the infusion went on for over 12 hours. Now, with levothyroxine, the dose could be decreased or discontinued based off of pre-specified hemodynamic variables from the study. And if they were to decrease the dose, they would reduce it by increments of 10 micrograms per hour. Now, after the 12-hour period, they could extend the levothyroxine infusion if the OPO had permitted it. And then the control group was actually eligible to receive levothyroxine after completing their 12-hour infusion with the normal saline. And just to note, donor care was not standardized across all the OPOs as they all had different policies and procedures. However, they did abide to the protocol otherwise. They included patients that had declaration of death according to neurologic criteria within 24 hours, and they had to have authorization for organ donation and research. They included those who were 14 to 55 years old, weighed more than 45 kilograms, and then categorized as hemodynamic unstable. So from this, they define this as receiving more than one vasopressor or inotrope after fluid resuscitation. However, they did exclude those patients that were receiving vasopressin or solely for diabetes insipidus. Now, they did exclude patients that received thyroid hormone within the past month, and they also excluded those that the hearts were not considered for transplantation due to various factors. And then if they were a donor at AVA hospital or had HIV positive status, they were excluded from the study. In terms of outcomes, so the primary outcomes for the donor was if the heart was donated or not, or transplanted. And then for the safety outcome was the graft survival at 30 days after transplantation. Then for secondary outcomes, they looked at if other organs were transplanted. They also, of course, looked at vasopressors because this would help us determine the actual effects on hemodynamic stability. So they looked at the duration, they required the vasopressor, the proportion of those that were able to wean off these medications at the end of the infusion. And then they also looked at the vasoactive inotropic score, or VIS, after 12 hours. VIS has its own calculation, so depending on what agents they are on, we come up with a number. And this number actually helps us quantify the degree of hemodynamic support. So what they found is that a higher VIS is associated with a poorer outcome in these patients. And then also time of initiation of infusion to time of the echo being ordered, and adverse events, so like hypertension and tachycardia, were evaluated. For statistical analysis, they calculated they would need 753 donors to achieve an 80% power and alpha of 0.05 to detect an increase of 10% in hearts transplanted. And then for outcomes, they used chi-squared test for hearts transplanted. For graft survival, they used non-inferiority margin of 6%. And then additional analyses they looked at was intention to treat, per protocol, and as treated. Now here are the baseline characteristics. You can see overall very similar between the levothyroxine group and the saline group. Just briefly, the average age for these patients was around 36 years old. The average weight was around 85 to 86 kilograms. Some coexisting conditions that they included was hypertension, diabetes, cigarette use, and cocaine use. The median time from declaration of brain death to start of infusion was about 8 hours. And they also looked at the cause of death, so whether that be anoxia, stroke, or trauma. Again, they looked at free T4 levels before the infusion started. And what we can see here, about 38% of our patients had low free T4 levels. And so that would mean like about 60% of our patients were within the normal range. And then lastly, the average VIS was around 10. Looking at the primary outcomes of this study, first looking at hearts transplanted, we can see that there is a very negligible difference between the two groups. And so this result was not statistically significant. And then from there, the hearts that were transplanted, we see that there was a pretty good success rate in terms of graft survival at 30 days in both groups. And again, very negligible difference. So we did not see a statistically significant difference in the primary outcome between levothyroxine and saline. Some secondary outcomes. Overall, there was not a statistically significant difference between these outcomes when you're looking at levothyroxine versus saline. However, I did want to highlight that we did see more cases of hypertension and tachycardia in the levothyroxine group, and that was at 12% versus the saline group around 4%. Other analyses is the subgroup analyses of the hearts transplanted. So what we can get from this image is that abnormal and normal ejection fraction, along with time from brain death to the infusion, showed no difference in hearts being transplanted between saline and levothyroxine. Now, this is a post hoc subgroup analysis of hearts transplanted as well. And what we can get from this image is that the VIS at baseline, the free T4 level, and cause of death show no difference in hearts transplanted between saline and levothyroxine, except for those who had died of stroke had favored saline more than levothyroxine. Now, these two images fairly show the similar thing. So it looks at the VIS score on the left, and then on the right, we see the vasopressor or requirements over time of the infusion. So what we can see here and get out of these images is that over time, while the patient was receiving these agents, we see a very comparable rate in the decrease of requirements. So overall, thinking back to the result with the ejection fraction and also looking at the vasopressor requirements, you see that there's no difference. I apologize.
Code blue, 11 feet Bravo, room 15, bed 2. Code blue,
Sorry about that, everyone. So essentially, so from this slide and looking at the results for the echocardiogram, we see that there was no difference. So this really just suggests that there's a lack of physiologic benefit in using levothyroxine on donor cardiovascular function. Now, the authors concluded from the study that IV levothyroxine did not show benefit for the number of hearts transplanted, improving hemodynamic stability, and then increase the donor cardiac function when compared to normal saline. Some strengths of the study included generalizability, so it really represented the target population that we wanted to look at with the hemodynamically unstable heart donors. And then in terms of the study protocol, there was a very high adherence to the protocol. No patient was lost to follow-up. And then obtaining T4 levels, I thought was a strength of the study because this, I felt, had helped the rationale looking at if levothyroxine would actually be beneficial either in those with normal T4 levels or those with lower T4 levels. And then I thought another strength was including levothyroxine use only, since we know from previous studies is that there's no clear benefit using T3. So this study helped us really hone in on T4 and not including those with T3. And then blinding the echocardiogram technicians, I felt was a strength of the study because this would help limit bias from those results as well. Some limitations of the study are that it is an open label study. They felt that it was not feasible to blind these patients across all of the different OPOs in the nation. And overall, they did feel obligated to let the patient know because there's this potential theory that thyroid hormone can help with cardiac function. I thought another limitation was how the practices and policies were not standardized amongst all the OPOs, so unsure how this may have affected the results of potentially they utilize other hormones in their resuscitation therapy than compared to others. Then for the levothyroxine dose, as we can think back to the SCCM guidance, they recommended 20 microgram bolus followed by a 10 microgram per hour infusion. And the study used a 30 microgram per hour infusion. So definitely a higher dose than what we see with the SCCM guidance. So unsure how this would also affect the results. So for clinical relevance and how we can apply to our practice is that we no longer need to use thyroid hormone for hormonal resuscitation in heart donors. As we didn't see additional benefit, there would be cost savings for both the patient's family and for the hospital. This would also limit adverse drug events that we see, as we know that adverse effects where we saw hypertension and tachycardia in the levothyroxine group. And then also considering IV compatibility, considering how much access the patient may have, this would help free up a line if we did not have levothyroxine on board. And then some future directions we can consider is standardizing a protocol for donor care and heart transplant, and then see maybe what the effect of thyroid hormone would be in non-heart donors. So some takeaway points from this study is that thyroid hormone does not provide additional benefit when utilized for organ procurement of heart donors. And since the OPTN does not really control or set standards in terms of medications, I feel that as pharmacists, we do have an opportunity to dive more into research of the pharmacologic aspects of donor care so we can help optimize this for our patients and make it more standardized across the nation. And that's all I have for you today, and I'd be happy to answer any questions.
Awesome. Thank you so much for that fantastic presentation. So at this time, we'd be happy to open the floor up to any questions. Certainly feel free to leave your questions in the chat, or you can definitely unmute and ask your question over the Zoom. So I guess I can certainly start and just ask, I'm curious, at your institution, does your practice include giving IV levothyroxine to your brain dead donors?
Yeah, so that's a really great question. So before the study came out, here at Grady, we do have a order set available. Our OPO is LifeLink, and so you would just type into the Epic order set, and it would come up with all the different exogenous hormones. And levothyroxine is included in there, and that dosing aligned with the SCCM guidelines or guidance. So we would do 20 micrograms as a bolus, and then 10 micrograms over 10 micrograms per hour, and then that was reconstituted in 200 micrograms in a 500 ml bag that was ran over like 20 hours.
And so in your experience, do you find that essentially all organ donors receive levothyroxine, or is there some selectivity in who receives it?
So personally, I haven't, I think I've had maybe one patient a few months ago that had to be put on levothyroxine, so I haven't seen it too much. But what I have seen is that when a patient is going to be considered for brain death and organ donation, LifeLink is here right away and always really involved with the team. And they are very helpful with at least guiding us of what we should do for these patients. And from my understanding, after this trial came out, a lot of OPOs and even LifeLink, since it was included in the study, they decided to take it out of their protocol. So we might see some changes in all of our institutions here soon.
Awesome. Thank you so much. Are there any other questions from the group? All right, so hearing none, thank you so much for your fantastic presentation. I am excited to introduce our next speaker. If you don't mind just stopping and sharing your screen so Dr. Burling can share hers. Dr. Madeline Burling is a PGY2 emergency medicine resident. She is going to be presenting our next article, which is on IV levetiracetam therapeutic drug monitoring in for seizure prophylaxis, which is certainly an interesting topic relevant to many of us. So please feel free to take it away. I'm very excited to hear your presentation.
Hi, thanks. Can you see my screen?
Sure can.
Excellent. Okay, well, hello, everyone. Like he said, my name is Madeline Burling. I'm the PGY2 Emergency Medicine Pharmacy Resident at North Kansas City Hospital in North Kansas City, Missouri. And today we'll be talking about an article titled Optimal Dosing of Levetiracetam for Seizure Prophylaxis in Critically Ill Patients. This was a prospective observational study that was published in Critical Care Medicine just a few months ago. Before we get into the literature, I would like to establish a foundation of knowledge for this disease state as a whole. Brain injury in the form of a bleed or trauma puts the brain tissue at risk for secondary injury, since it is typically caused by, puts the brain tissue at risk for secondary injury since it's typically caused initially, and then there's other things that happen that causes some extra injury to the brain. So this could be blood in the brain, this could be inflammatory markers and things like that. So the body compensates for injury with inflammation, which causes a downstream release of several different receptors that activate hyperexcitability pathways. If the brain experiences too much inflammation, it can also cause electrophysiologic disruptions, exceeding its available space. The blood-brain barrier effectively separates the brain tissue from various electrolyte concentrations, osmolality differences, and corrosive agents like blood itself. Altering the barrier causes disruption in the electrophysiology, which is usually tightly regulated. Astrocyte changes occur as a result of injury and can create scar tissue. This typically is helpful in the healing process, but can also disrupt the electrophysiological currents in the brain. After TBI, people are in a hypermetabolic state, and that actually increases glucose metabolism that can lead to changes in brain excitability as well. Or if the trauma or injury is caused in a site of the brain that regulates glucose metabolism, this can also cause hyperexcitability and issues with seizure prevention. Now we'll talk about the guidelines a little bit for these different disease states. The guidelines, widely speaking, do not give clear, concise, up-to-date recommendations regarding the type and regimen of anti-seizure medications for post-injury prophylaxis. The Neurocritical Care Society presented a new guideline statement at SCCM back in 2022 that suggested that if used, levetiracetam should be used over phenytoin and fosphenytoin for no more than 7 days if anti-seizure medication for prophylaxis is to be pursued. These statements were never officially published though, so please know that they are still subject to change at this time, but I wanted to include them since they are the most up-to-date information regarding TBI that we have. For subarachnoid hemorrhage, the AHA and ASA do not recommend anti-seizure medications unless they are at high risk, which you can see I've defined there. They do make a statement, however, recommending against phenytoin due to excess morbidity. For intracranial hemorrhage, as you can see there, it's pretty cut and dry. They do not recommend anti-seizure medication for prophylaxis. Overall, there is not a clear dosing regimen, there is not a clear timeline or obvious recommendation for or against prophylaxis in brain injury. We'll start our literature review with this systematic review and meta-analysis from 2022 titled Levetiracetam for Seizure Prophylaxis in Neurocritical Care. They looked at 30 different studies between 2000 and 2020, and they looked at levetiracetam for seizure prophylaxis after a number of different disease states listed there. Primarily, they looked at whether there were seizure events. So this was composite of both clinical and electrographic. They looked at levetiracetam versus no anti-seizure medication versus, and they also looked at levetiracetam versus another anti-seizure medication. Secondarily, they broke down each of the disease states and looked at the data and did a sub-analysis of those. So the results here for the primary analysis were there was no difference in seizure events, both for no anti-seizure medication compared to levetiracetam or levetiracetam versus another anti-seizure medication. So this is kind of interesting. It's not maybe what we would expect to find from this data, but we'll talk about that in a second. Secondarily, they found the only disease state that did show some benefit that was statistically significant was the supratentorial neurosurgical disease states. And they benefited in levetiracetam versus other anti-seizure medications, but again, not when compared to no anti-seizure medications. They found no difference with those other disease states and types of injury that I mentioned. For the dosing, this is where I want to spend a little bit of time for this systematic review and meta-analysis. So commonly, they used 500 milligrams twice a day in 11 of the 23 studies. You may remember that I said that there were 30 studies, only 23 of them reported the doses that were used. So that's where these ratios are coming from. They also reported that as low as 250 milligrams twice a day was allowed in 6 of the 23 studies. So that's over a fourth of the studies that were reviewed here were allowing doses as low as 250 milligrams twice a day. And then they also looked at weight-based or doses greater than 1,000 milligrams twice a day, and those were in 6 of the 23 studies as well. So we kind of have a wide range of the different doses that were used in the studies and analyzed in this meta-analysis. So they concluded that, these studies produced results that were possibly biased. There was a pretty high risk of bias in all of the different studies. And then they also concluded that it was very likely underdosed. In most of these studies, they used lower doses like 500 or even less than that in more than half of the studies that they analyzed altogether. And those were just the ones that included the dosing regimen. So we're not even sure on the ones that didn't, which doses they were using. So I find this interesting, and I just want to make sure that we think about this and know that, yes, it didn't show difference in seizure events, but it was very likely underdosed from what we know to be true today. The next piece of primary literature that I want to go over is what you may know as the PEACH trial. It was actually titled Safety and Efficacy of Prophylactic Levetiracetam for Prevention of Epileptic Seizures in the Acute Phase of Intracerebral Hemorrhage. Like I said, PEACH trial. This was a randomized, double-blind, placebo-controlled phase 3 trial that looked at 50 adult patients from 2017 to 2020 that had mild to moderate, non-traumatic ICH. There's a few different stroke units in France, and they looked at levetiracetam versus placebo. Okay, so the primary endpoint that they looked at was at least one clinical seizure within 72 hours of inclusion, or one electrographic seizure recorded on continuous EEGs. So they primarily saw that there were 3 seizures in the levetiracetam group, and then 10 seizures in the placebo group. So this was statistically significant, as stated there. The p-value is less than 0.05. However, all of those seizures were electrographic seizures only, which is, I think, worth mentioning because we'll talk about a little later the clinical significance of electrographic seizures versus clinical seizures. They concluded that the study showed that levetiracetam at a dose of 500 milligrams twice daily decreased the frequency of electrographic seizures reported. And this was true, but there were several issues with this study that people brought up. They did miss their power, unfortunately. If you notice there, the numbers of patients in each of the groups were less than 30. So all in all, they had about 50 patients. They missed their power by about half. So unfortunately, the study did have a fragility index of about 0, meaning that a different outcome in one patient in either group could have altered the study's statistical significance. They also did not report how many people were eligible for enrollment but not enrolled. So there may have been a risk for some selection bias, just given that they did have so few patients included from about 3 years of data. And then I will let you know too that the baseline characteristics were a little bit different between the groups. So the NIHSS was higher in the placebo group, and the hematoma volume was almost twice the size in the placebo group as well. So this could have also been leading to some of those higher numbers of seizures that we were seeing in the placebo group. Additionally, like we kind of mentioned or alluded to, the long-term impact of preventing subclinical seizures or preventing clinical seizures but seeing them on EEGs, it's kind of uncertain what that benefit is, and it's unclear whether those seizures even led to worse outcomes. Okay, now I just want to provide a little bit of background regarding levetiracetam and its therapeutic level. So the therapeutic level that's accepted in most of these studies is 12 to 46 micrograms per milliliter. I wanted to just kind of put that out there so that you know going into our journal today, and that is from the International League Against Epilepsy. And several other studies use this range as well. This is a wide range, and it does have some inconclusive evidence. So studies have not demonstrated clear association between reaching therapeutic levels and improved clinical outcomes. So just keep that in mind as we move forward. Just a little bit of pharmacokinetic background here as well. So critically ill patients, as we know, often have increased inflammatory markers leading to vasodilation. This kind of increases our blood flow throughout the body to and through the kidneys at times. And this actually may result in subtherapeutic drug concentrations, just because our creatinine clearances may be reaching upwards of 130 plus milliliters per minute. So this is what I'll refer to here on out as augmented renal clearance. And I think that it's something that's relevant given that we know that levetiracetam is renally excreted. So just to summarize our background here, the literature really has yet to show benefit in prophylaxing against clinical seizures. And the available literature has not suggested a dose surely for levetiracetam prophylaxis. They've looked at a few different doses. The PEACH trial looked at 500 twice a day. But that systematic review and meta-analysis was kind of all over the map in terms of their dosages. The target levels were 12 to 46, which is what we usually accept. And then the pharmacokinetics, just remember that oftentimes these patients, especially with TBI, et cetera, have augmented creatinine clearance. So now getting onto our article at hand, we have the optimal dosing of levetiracetam for seizure prophylaxis in critically ill patients. The objective of this study was to compare high versus low doses of levetiracetam in prophylaxis against those listed disease states. So traumatic brain injury, subarachnoid hemorrhage, intracranial hemorrhage, and supratentorial neurosurgery. Our high dose was defined here as 750 or 1,000 milligrams twice a day, and our low dose was the 500 twice a day that the PEACH trial used. This was a single center prospective quality improvement project from 2019 to 2021. I want to just mention here, it is prospective, but it's not controlled. It's more observational. So they were noticing certain patterns at their institution, and they decided to do this study as more of an observational going forward to look at these things. And that's what makes it prospective, but just keep in mind that it is not controlled. So like I said, they noticed some institutional practice variation. Primarily their providers were prescribing 500 milligrams twice a day of levetiracetam for seizure prophylaxis, but they noticed that some practitioners were using higher doses. So they decided to look into that, compare the two, and get levels prior to the fourth dose at steady state. They did do EEG recordings, and it was at the discretion of the treatment team. So it was not continuous monitoring, and it was not necessarily like every third dose or anything like that. It was at the discretion of the treatment team. Primarily, they looked at target serum levetiracetam levels from 12 to 46. And then secondarily, they looked at whether they had a clinical or electrographic seizure, if they had epileptiform discharges, and if they had changes in levetiracetam dosing or early discontinuation of that levetiracetam. They included anyone that was 15 to 90 years old who received levetiracetam at admission for the purpose of seizure prophylaxis. And then they had to make sure that the levels were obtained properly, given that that was their primary endpoint. So they excluded people who did not meet that criteria, who had a history of anti-seizure medication use, if they had renal failure that required dialysis, if they got less than 4 consecutive doses of levetiracetam, or if they had an inappropriate timing of that level, again, because that was their primary endpoint. Here is their breakdown of their population. So they looked at 1,145 patients with those disease states. 856 were initially included or excluded because they were not prescribed prophylactic levetiracetam. If they had a seizure prior to admission, prescribed, a lot of them were prescribed anti-seizure medications before admission, or if they were out of the age range, of course. 289 patients were initially included, and then 84 of those ended up being excluded due to incorrect timing of levels. So they were kind of excluded once the study got going. This left 205 patients, which is what we analyzed. 99 patients had high-dose levetiracetam and 106 received low-dose levetiracetam. Here is the results, or the demographics. And I like to include this because I want to talk about a few of these. So all the demographics were similar except for age. And that is just that it was just like very slightly different. It was a little bit older in the 500 milligrams twice a day group. The next one that has statistically significant difference is the loading dose. But again, we would expect this to be a little bit different because no one is going to load with 500 milligrams, for example, if they plan on giving 1,000 milligrams twice a day. So although those are the same, the intervals are a little bit different because some of the 500 milligrams twice a day, their first dose was the 500 milligrams. So that difference makes sense. And then again, the difference between the two groups was the overall dose. So it makes sense that when broken down by milligrams per kilogram, it would be different on both of those per day, percentage-wise and median dose. Okay, so this is the univariate analysis that they included. So their primary outcome of those that reached therapeutic serum levels was statistically significantly different. So in the low dose, only 48 people reached that level versus in the high dose, 63 did. This was statistically significantly different. In their secondary outcome, they did also have a difference in their composite seizure occurrence. So more people had some sort of seizure, either clinical, electrographic, or both, in the low dose group than in the high dose group. So this is interesting. And then again, that extends into the electrographic seizures. More people had electrographic seizures in the low dose group than in the high dose group. I will call attention right there though it is trending toward more clinical seizures in the low dose group as well, it was not statistically significantly different. So unfortunately, we're still not seeing that big difference in the clinical seizure perspective. This, I know it's a busy table, but we're going to go through it one by one with the statistically significant different values. So this was a multivariable analysis that looked at therapeutic versus non-therapeutic levels. So this did a good job of kind of giving us some information that we're wanting to see when it comes to if patients are therapeutic, what does that mean for their clinical outcomes? So more people reached therapeutic levels if they were a little bit older, which is interesting, and if they had slightly higher BMI actually. But if you notice, both of these confidence intervals do include 1.00. So I'm not, it's not a extremely obvious clinical difference based on the odds ratio. However, you can see there that some of the older age and a little bit of a higher BMI do make a difference with the therapeutic levels. This is one that I'll spend some time on over the next few slides. The creatinine clearance was lower in those that achieved therapeutic concentrations. So we'll keep that in mind, and that was a little, it also includes 1.00, but it's a little bit more clinically significant of almost 20 milliliters per minute different in their creatinine clearance. And then for the maintenance dose and the maintenance dose milligrams per kilogram per day, of course, these were different. Oh, no, sorry, excuse me. These were different between the groups. This is what we were looking at. And if you will notice, we did achieve more therapeutic levels with the higher dosage range. So that first maintenance doses of the higher range had 63 people who achieved therapeutic levels versus just 36 people who were non-therapeutic. And then again, this is based on weight, so milligram per kilogram per day. Those with a higher milligram per kilogram per day achieved therapeutic levels more likely than those with a lower dose. This is another multivariate analysis that looked at seizure versus no seizure and kind of looking at some of the different variables that played a part in whether or not they had a seizure. So they did look at, if you can see here, so they did look at creatinine clearance once again was higher in those who had a seizure. So this is kind of thought-provoking in if their seizure or if their creatinine clearance is a little bit lower, they were more likely to have therapeutic levels, and then they were more likely to have no seizure just based on their creatinine clearance as a variable alone. So that was kind of interesting. And then the only other two that I wanted to mention here, again, the higher doses were more likely to have a no seizure, and higher milligram per kilogram per day were more likely to have no seizure than if they were to have the lower doses. Once again, this is just another way to show that creatinine clearance and the higher weight, like milligram per kilogram per day dosing, might make a difference when it comes to having a seizure. This graph is a visual representation of the results that we discussed. It shows the difference between high and low dose levetiracetam when it comes to seizure-free days from admission. So this ends at the final follow-up, which was at 800 days. And like I said, it's a visual representation that, again, the high dose levetiracetam has significantly more seizure-free days than the low dose levetiracetam. All in all, the authors concluded that use of the higher dose levetiracetam for seizure prophylaxis was associated with increased odds of achieving target drug levels and lower rates of seizures. There are a few things that I wanted to discuss here. So I want to talk about the type of seizure a little bit with this electrographic versus clinical seizures. So there is kind of a question out there of, do electrographic seizures have clinical relevance? Neither type has really been shown to increase mortality, but could preventing them still improve outcomes? These are the questions that I have, and it was trending toward less clinical seizures as well, and they did reach statistical significance when combining the two different types. But I do think it is interesting to think about, what does it really mean to have a clinical seizure versus a subclinical seizure on an electrocardiogram, or sorry, electroencephalogram. And then for renal function, and then the dose per weight, kind of like I was talking about on the multivariate analysis, the most consistent differences in seizure incidence and achievement of therapeutic levels had to do with a little bit lower renal function and a little bit higher dose per weight. So I think in suboptimal renal function, this kind of begs the question of, what should we do with the people who aren't going to tolerate the higher doses of levetiracetam? Unfortunately, those people with a low creatinine clearance were pretty much excluded from the study. Most of the average creatinine clearance starting out was pretty high overall. And so I'd be interested to see what the study would have shown if the average creatinine clearance at baseline was much lower, if we would have needed lower doses and things like that to avoid adverse events and things of that nature. If your creatinine clearance is adequate, which is kind of what they showed in this study, the 750 to 1,000 seems very likely to put the patient in a therapeutic range and avoid seizure activity. They didn't really, it's hard to decipher out the augmented renal clearance though. It does make me wonder if someone had augmented renal clearance of an estimated creatinine clearance over 130 or something like that, if they might even need higher dosages or more weight-based dosages to reach those therapeutic levels. So I don't know if, I wish there could have been a time where they checked a therapeutic level, and if low, increase it to 1,500 milligrams twice a day or something along those lines. So those are some of the things that I'm thinking about when I'm looking through this study. And then they did combine the disease states. So the guidelines are often different for these different disease states, and a lot of the studies do break up the disease states, but in this article, they combined them all together for all of those seizure and outcomes and things like that. So some strengths of this article I found is that it does fill some gaps in the literature and guidelines. It looks specifically at doses, it looks at therapeutic levels as compared to clinical outcomes. So I liked that about it. And then I think it was very strong in its statistical analysis. I felt that each of the multivariate analyses made it easier to tell how we can apply this to our practice and kind of draw our own conclusions when it comes to looking at the statistically significant differences in each of those different variables that they analyzed. I also feel like the groups were really well matched across the different variables, even the EEGs that were a little bit more subjective, and when they got them, they were consistent across both of the groups. So that's something that I was impressed with, given that there was some subjectivity. A lot of their and it was mostly just observational, it wasn't controlled, their groups really were well matched. And then their population size was really good for a study like this. The power was set and met. So I feel more confident in some of the data in that setting too. Some limitations, there was some subjectivity and opportunity for bias in the methods. It was mostly unblinded. A lot of the people who kind of knew the doses and things were helping to remind people of when to draw levels. So this could have led to some bias when it came to selection for the study versus exclusion. Like I said, it was uncontrolled, and then it was based on things that they were seeing at their institution. So it makes me question the external validity a little bit. But overall, my conclusion is that based on this study, I am much more likely to recommend a higher dose of levetiracetam twice a day for seizure prophylaxis following any sort of brain injury. I do hope that further studies are done to assess for optimal doses and like what the clinical relevance is of some of these outcomes that each of these studies are looking at. What questions do you have?
Awesome. Thank you so much for your fantastic presentation, Dr. Burling. So if anyone has any questions, feel free to place those in the chat, or feel free to unmute and ask those over the call. So So I'm happy to start. I think one thing that I found curious about this paper was particularly in that time to event survival curve that you presented, a large portion of the seizures happened fairly late, but the median duration of seizure prophylaxis was only 7 days. So I'm
Right.
curious what your thoughts were in terms of whether or not the findings of this may be relevant, particularly in that context.
Yeah, that is interesting. I noticed that too, that it was happening almost like a year down the road. Like some of them were dropping off around day 400. So I'm not sure that this study really studied that. I'm not sure that it was really looking at duration of seizure prophylaxis. That would be interesting though, because the guidelines are mainly saying like the earlier ones are more relevant for clinical outcomes, like, mortality and things like that. So I'm wondering if that was just kind of outside of what they wanted to look at, but I do find that interesting as well that it was happening way later. Um, yeah, yeah, that is a good
Yeah,
question.
it is interesting. It's kind of like a difference in how they evaluated their outcomes and
Yeah.
what was actually given. There is a question in the chat that's asking, what creatinine clearance cutoff would you use for a higher dose recommendation?
Oh, for like the 750 to 1,000?
I believe so, yeah.
Yeah, that's a good question. I mean, I would probably still follow what the like package insert with the drug information states about renally adjusting levetiracetam. But I think that right now a lot of people's practice is that anyone who has a TBI that's getting seizure prophylaxis starts at the lower dose of 500 milligrams twice a day. I know that that's a lot more common at our institution, kind of no matter their creatinine clearance. So as long as it doesn't need to be renally adjusted, I think that we should start off higher and then adjust as necessary down rather than starting lower and adjusting as necessary down. Does that make sense?
Yeah, and I think right along those lines is an excellent question from Dr. Cook, who's asking, based on the results of this study, should we start doing TDM in all of these patients?
That's a good question. That was something that I was questioning as well. Especially for people who we think about might have augmented renal clearance or who are maybe, who are very young or who have, like we're estimating them to be running through things really quickly. If they are a little bit bigger, way more, we could think about what's their dose per kilogram per day, kind of like what we were looking at. Those people, and then like I said, the younger people, the people with really augmented renal clearance, and then the people who might have less of a milligram per kilogram per day. Those are people that I would actually be curious to see some of the levels on more often. Whereas if we have someone that's kind of sitting where these people were, their creatinine clearance, I believe, was like, 70 to 90 estimated. Like, I think that we can go ahead and assume probably that they're therapeutic with those just based on the study. But there are some people that fall into those other populations that might not be therapeutic that we saw today. And those are the people that I'd be interested in seeing a therapeutic drug level on.
It sounds like a more targeted approach, which kind of what you're.
Yeah, targeted approach is what I would
Yeah, I
use.
mean, that sounds like a fairly reasonable strategy, maybe a good opportunity for some multi-center research collaboration, because I think there's definitely more work to be done in this space. So we are at the top of the hour. If anyone has any last minute questions, feel free to put them in the chat. But if not, thank you so much to everyone who joined today's Journal Club. I hope you all learned a lot about these very interesting studies, and I want to deeply thank the presenters as well as their mentors for putting in the work and helping to educate us about this new content. If you are interested, please continue to have the discussion on Twitter. Make sure you use the hashtag NCSPharmJC, and we hope to see you at our next Journal Club in the next 2 months.